If you've had a biopsy, chest tube, or other procedure for mesothelioma, you might be told you need prophylactic radiation to the procedure site. Prophylactic radiation is given to prevent tumors from growing along the tract where the needle or tube entered your body. This sounds reasonable in theory, but does it actually work? Today I want to explain what tract seeding is, why prophylactic radiation is sometimes recommended, what the research shows about its effectiveness, what the treatment involves, and what some experts say about whether you should have it. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician, and this isn't medical advice. But understanding the evidence or lack of evidence for prophylactic radiation helps you make informed decisions about whether to undergo this treatment. Let's start with what tract seeding is and why it's a concern. When you have a biopsy, thoracentesis to drain pleural fluid, chest tube placement, or other procedures that penetrate through the chest wall into the pleural space, a pathway or tract is created through your skin, muscle, and chest wall. The concern that raises the issue about prophylactic radiation is that mesothelioma tumor cells might be carried along this tract as the needle or tube is withdrawn, and that they can then get implanted along the pathway and over weeks to months could grow into tumor nodules along the tract or even at the skin entry site. When this happens, it's called procedure tract metastasis or tract seeding. The nodules appear as painful lumps along the procedure site or at the skin entry point. They can be quite uncomfortable, and sometimes the ones below the skin actually break through. How common is tract seeding without prophylactic radiation? Older studies from the 80s and 90s suggested that tract seeding occurred in 20 to 40% of mesothelioma patients who had these types of procedures. These high rates were what led to both the concerns and recommendations for prophylactic radiation. However, more recent studies with modern techniques suggest that the actual incidence is much lower, probably more like 5 to 15%. The older studies might have overestimated the problem, or it could be that modern surgical techniques and instrument design have reduced the risk. Now, before I go on, I'm going to take a break here to ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comment section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that will make a real difference for you. So, what is prophylactic radiation? The idea is to give radiation to the procedure tract and entry site shortly after the procedure, typically within a few weeks, to kill any tumor cells that might have been implanted. That prevents tract metastasis from developing. The typical approach is to deliver the radiation to the tract area in 3 treatments over 1 week, with each treatment taking about 15 to 20 minutes. The radiation field encompasses the skin entry site and the path through the chest wall to the pleura. Because it's only 3 treatments to a small area, side effects are generally minimal, maybe some skin redness at the entry site. It's relatively quick and easy compared to longer radiation courses. But does prophylactic radiation actually work? Here's where the evidence gets complicated and disappointing. Multiple studies have looked at this question, and the results are mixed and mostly show no clear benefit. The most rigorous study was a randomized control trial published in The Lancet Oncology in 2007. This United Kingdom-based trial randomized mesothelioma patients who had procedures to either receive prophylactic radiation within 42 days of the procedure or no radiation, with the primary investigation being to see whether tract metastases developed. The results showed no significant difference. 9% of those who received the prophylactic treatment developed tract metastases versus 16% of those who didn't. That's not a statistically significant difference. And the trial concluded that The prophylactic radiation didn't prevent procedure tract metastasis and was generally not recommended as a routine practice. Another review was conducted in 2016. It examined all the available studies that had been done up to that point, and the researchers found the same thing. There was insufficient evidence to support prophylactic radiation to prevent tract metastasis. Still, practice varies widely. Some centers routinely give prophylactic radiation after procedures, and others never do. And some take a selective approach based on individual factors. So what might explain why it doesn't work as well as expected? There are several options. It could be that the radiation is given too late. If it's given 2 to 4 weeks after the procedure, tumor cells implanted during the procedure might have already started growing and the radiation dose isn't high enough to kill established tumor material. Another theory is that the radiation field might miss some of the tract. It's tough to know exactly where tumor cells were deposited, and radiation fields might not cover the entire risk area. Tract metastasis might develop from spread within the pleural space rather than from the procedure seating. If tumor cells are already floating in the pleural fluid, they can implant at procedure sites regardless of whether seeding occurred during the procedure. Radiation doesn't prevent this, and the baseline risk of tract metastasis might be lower than previously thought, making it hard to show benefit. If only 5 to 10% develop them without radiation, you'd need to treat a lot of patients to prevent just one case. Are there any situations where prophylactic radiation might still be considered? Some radiation oncologists selectively recommend it for patients who have a very bulky tumor at the procedure site. That represents a higher risk of cell transfer. And another scenario is when patients' tumors are of the sarcomatoid cell type, which is more aggressive and may have a higher seeding risk. For patients who are going to undergo other radiation anyway, adding the tract to the treatment field adds minimal burden, but doing a separate radiation course solely for prophylaxis is harder to justify given the lack of evidence. What if you develop tract metastasis despite prophylactic radiation or without having had it? If the nodules develop along a procedure site, radiation can be given as treatment rather than prevention. Palliative radiation to establish tract metastasis is quite effective for pain relief. 70 to 80% of patients experience significant pain reduction. The radiation dose for treating established metastasis is higher than prophylactic. While not eliminating it, it usually still provides good pain control. Some tract metastases can be surgically removed if they're causing significant problems, and they're often localized enough for that to work. What about for other procedures beyond biopsies? The same questions about prophylactic radiation apply to chest tube sites, thoracoscopy port sites, and any other procedure penetrating the chest wall. Some surgeons who perform pleurectomy decortication include all procedure and port sites in the post-operative radiation field if radiation is given after surgery. This addresses tract seeding risk as part of the overall radiation plan. What should you do if this prophylactic radiation is recommended to you? Ask why. Ask why, especially because there's no evidence showing any clear benefit. Understand it's reasonable to decline prophylactic radiation, to only have radiation if the metastases actually develop. If you're already having radiation for other reasons and adding the tract site to the treatment field is simple, that might be reasonable. But undergoing a separate radiation course solely for prophylaxis isn't supported by strong evidence. Ask about the local practice pattern. Do they recommend this for all patients or just selected cases? What has their experience been with tract metastases in patients who don't receive the prophylactic radiation? The bottom line is that while prophylactic radiation seems logical and some centers still recommend it, the best available evidence from randomized trials and systematic reviews shows it doesn't significantly reduce tract metastasis risk. This is one situation where standard practice at some centers isn't supported by rigorous research. To review, prophylactic radiation to procedure tracts aims to prevent mesothelioma tumor seeding along biopsy, chest tube, or other procedure sites. It's typically given in 3 doses over 1 week to the tract area, but the largest randomized trial showed no benefit. 9% metastasis with radiation versus 16% without, which isn't statistically significant. And another high-level review also concluded there was insufficient evidence to support its use. Tract seeding may be less common than previously thought. Still, practices vary widely. Some centers routinely use it and others never do. It's important to know that if tract metastases do develop, radiation can effectively relieve the pain and they may be able to be surgically removed. Given the lack of evidence, it's reasonable to question or decline prophylactic radiation. You can visit mesothelioma.net for information about radiation therapy and mesothelioma treatment, or call 1-800-692-8608 or use the live chat feature on our website to speak with a patient advocate right away. As for me, remember to post your questions below, and I'll see you next time.